So, a very good morning to everyone. I, Dr. Poonam Joshi, welcome you once again to our head and neck academic classes. Our speaker is Dr. Abhishek Vaidya. Dr. Abhishek is senior consultant at Nagpur at NCI, and he will be speaking on the surgical anatomy of salivary glands. This will be the part two, where he will be telling us the anatomy of submandibular, sublingual, and the minor glands. And I thank Dr. Abhishek because he kindly agreed to take the second class. And Dr. Abhishek, you can share the screen. Hello.
Yeah, good morning, everyone.
Dr. Abhishek is muted. Can he be unmuted? Hello.
Yes, I'm just sharing my slide in a moment. Last time I shared this just crashed. Just give me a moment before I share this. Just give me a moment, please. So we covered parotid glands last time.
I think Abhishek, the screen is not nice.
This time we'll be talking about the...
Hello, Abhishek. Hello. Hello. Hello, Abhishek. Hello. Hello. Abhishek, can you hear me? Hello. Hello. I think Dr. Abhishek is facing some internet issues. I think he is joining back. Please wait for 2 minutes.
Seen and heard now? Dr. Poonam?
We can, we can hear you.
Yeah, so I twice tried to share it and my Zoom crashed. So I have now logged in from a different device.
Yes.
Apologies for this. I will share right away. Okay.
Yes, Abhishek. We can see this. Yes.
Thank you so much. So this is part two of the surgical anatomy of salivary glands. Last time we spoke about parotid glands, and we spoke about some of the steps of applied anatomy and steps of surgery. This time is going to be a shorter one, and we'll take questions at the end regarding steps of surgery of the parotid or the submandibular gland. Now let's begin with submandibular gland. We know that submandibular salivary gland is the second most embryology. This usually develop shaped ends of these then grow into the underlying mesenchyme. Now the gland has two parts: the connective tissue, which is derived from the neural crest cells, and the secretory or the parenchymal part. This is derived from the proliferation of the oral epithelium. So the gland has mesenchymal as well as secretory components, and as such, tumors of all types can develop within the gland. So this is a typical arrangement of how the gland is. There are groups of mucous alveoli and there are groups of serous alveoli, and they are both in adjacent position to each other. The typical distribution, as I said, is about 3:2. So now let's look at the superficial and the deep parts. The superficial part fills the digastric triangle. It extends upwards, deep to the mandible, up to the mylohyoid muscle. It has an inferior, lateral, and the medial surface. Now, this part is the part of the gland which is usually seen and palpated. It partially is enclosed between two layers of the deep cervical fascia. Now, this is an important point, and we'll come to the applied anatomy of it when we discuss in the next few slides. The superficial layer of the fascia covers the inferior surface of the gland, and it is attached to the base of the mandible, whereas the deep layer covers the medial surface of the gland, and it is attached to the mylohyoid line of the mandible. So in other words, the gland is enclosed in between the two layers of the fascia, or the fascia is invested by the gland. Now, fascia enclosing the submandibular gland, I said this is an important thing. The middle layer of the deep cervical fascia encloses the submandibular gland. This is clinically relevant because the marginal mandibular nerve is superficial to it. So how do we preserve this nerve at surgery? At surgery, if oncologically appropriate, for example, if there are no nodes at 1B, or if you're doing a submandibular gland resection for a benign lesion or for chronic calculi, then a simple thing to do is to divide or to incise the submandibular gland fascia. When this is not possible, or when there are perifacial nodes, then you should meticulously identify the marginal mandibular nerve. The marginal mandibular nerve, as we discussed in the previous section, will be seen about a centimeter below and anterior to the angle of the mandible. The other method, which was popular while doing neck dissection, is the Hayes-Martin method. Now, what does the Hayes-Martin method say? You have to divide and ligate the facial artery, that is a distal part of the facial artery at the lower border of the mandible, and the upper ligated you have to hold with a mosquito and retract it upwards so that the marginal mandibular nerve will be preserved, and then you keep on incising deep to it. But an important word of caution is that when you're doing neck dissections, especially for buccal mucosa or gingival cancers, there is the likelihood of perifacial nodes here. So Hayes-Martin method or incising the fascia will not be a safe method. The ideal way to do it is meticulously identify the marginal mandibular nerve and then dissect. So I intersperse this point of applied anatomy here because it's very relevant to understanding the layers of the fascia. Now, once again, relations. As I said, now this once again is about the superficial lobe. There are inferior and the lateral surfaces and the medial surface. The inferior surface is covered by the skin, platysma muscle, cervical branch of the facial nerve, deep fascia, facial vein, and the submandibular lymph nodes. And the submandibular lymph nodes will be the perifacial nodes or the gland or the nodes associated with the gland. So they will be in contact with the inferior surface as well as the at the superficial aspect of the gland. The lateral surface is related to the submandibular fossa of the mandible, the insertion of the pterygoid, and the facial artery. As you can see, this is the relations of the submandibular gland from the medial aspect. The medial surface may be divided into three parts: the anterior, middle, and the posterior part. The anterior part, as you can see, is related to the mylohyoid muscles, nerves, and the vessels. The middle part will be related to hyoglossus, styloglossus, which is on the medial aspect, and the submandibular ganglion and the hypoglossal nerve. I'm going to show all of this in a video by Ackland. And the posterior part is related to the styloglossus, stylohyoid, the ninth cranial nerve, and the wall of the superior part of the pharynx. Inferiorly, it overlaps the stylohyoid and the posterior belly of the digastric. So once again, this diagram illustrates all the medial relations of the medial surface of the submandibular gland. Anteriorly, the mylohyoid; in the middle part, the muscles of the tongue; and the posterior part, you will get the styloid apparatus muscles. So deep part is smaller in size. It lies deep to the mylohyoid and superficial to the hyoglossus and the styloglossus. Okay, it is enclosed in between the mylohyoid on one side and the hyoglossus and styloglossus on the opposite side. Posteriorly, it continues with the superficial part of the posterior border of the mylohyoid, and anteriorly, it extends up to the posterior end of the sublingual gland. So on one side of the deep part is the superficial part of the submandibular gland, and on the deeper aspect is the sublingual glands. So this is once again a cross-sectional demonstration. This is taken from BD84 anatomy. You can see the cross-section of the muscles. This is the anterior belly of digastric mylohyoid. You can see how the submandibular gland curves around it. So this appears to be the superficial part of the gland. This appears to be the deep part of the gland. Now, deep part is enclosed laterally by the mylohyoid, and on its deep or the medial surface are the hyoglossus and the styloglossus muscles. The submandibular duct is also known as the Wharton's duct. It is thin-walled and about 5 centimeters long. It emerges at the anterior end of the deep part of the gland. It runs forward on the hyoglossus between the lingual and the hypoglossal nerves. Once again, I'm going to show a video which will demonstrate all of this well. At the anterior border of the hyoglossus, the duct is crossed by the lingual nerve. It opens on the floor of the mouth on either side of the frenulum linguae. So this is a demonstration or a picture of the submandibular duct. You can see how it's crossing the lingual nerve and then opening on the inner aspect of the mandible on either side of the frenulum linguae on the ventral surface of the tongue. Sorry, right. So this is the video. This video is taken from Ackland's anatomy, and I encourage all residents and students to always refer to this Ackland's anatomy before embarking upon surgical dissections or even surgery. So we begin where the submandibular gland has been removed, and this is just the borders of the submandibular gland. You can see the submandibular triangle very well into picture, which is superiorly bounded by the inferior border of the mandible, anteriorly by the anterior belly of digastric, posteriorly by the posterior belly of digastric, which is enclosed within this muscle, which is the stylohyoid muscle, right? So continuing into this, that is the hyoid bone, anterior belly of digastric, posterior belly of digastric enclosed within the stylohyoid. That is the stylohyoid muscle. You can see this is the mylohyoid muscle, and this is the styloglossus muscle. Posteriorly there is the hyoglossus muscle. This is a position where the gland has been removed. Now we'll add the gland. You can see that this is the superficial part of the submandibular gland. This is the part which is seen and palpated. It curves around the mylohyoid to form the deep part. And this part is situated at the angle of the mandible, going posterior-medial to it. Deep part is seen here after cutting the superficial part. And this is the extent it lies between the mylohyoid and the styloglossus and the hyoglossus muscles. We move on to the next video. Here we'll see the inner aspect of the submandibular gland. For this, we'll be taking a composite picture of the oral cavity, tongue, mandible into picture, and the alveolar process has been removed, and the mucosa of the tongue will also be removed for us to understand, one, the sublingual glands, and two, the submandibular duct or the Watten's duct. So this is a picture with the alveolar process removed. This is the tongue. Let's remove the mucosa of the tongue. And what you can see there is the sublingual gland. It's a diffuse flat gland. Let's remove the sublingual gland also. Now that what can be seen coming from before anteriorly is the submandibular duct. It courses anteriorly and medially to open on either side of the frenulum. Now let's go around and see where this is emerging. This is emerging from the anterior aspect of the deep part, where it lies between these two muscles, the mylohyoid muscle and the styloglossus and the hyoglossus muscles. It then passes anteriorly forward, medially, along the ventral surface of the tongue, deep to the sublingual gland, and opens anteriorly. Now this is the sublingual gland again added into the picture. This is a flat, somewhat diffuse and ill-defined gland on the ventral surface of the tongue, and it opens with several ducts on the mucosa of the ventral surface of the tongue. The ducts cannot be demonstrated as such. So I hope with those videos from Ackland's anatomy, the surgical anatomy of these two glands is well understood. In the next few slides, we'll see some more aspects related to anatomy, such as the blood supply, the nerve supply, which is important in case of submandibular gland, and some applied aspects. So the blood supply is by the facial artery. Now the facial artery actually courses through the submandibular gland. You can, when you're doing neck dissections, and especially when you're doing vessel preserving neck dissections, you can see that the proximal part of the facial artery enters the inferior part of the gland. It arborizes within the gland, gives at least 2 or 3 name branches within the gland. One is the submandibular artery, one is the submental artery, and one is the artery along the hypoglossal nerve. And it then emerges at the superior aspect of the gland, where it then passes onto the face, crossing the angle of the mandible, crossing the inferior aspect of the mandible. The veins, on the other hand, they all coalesce and they drain into the common facial vein or the lingual vein. There is a distinct anatomical variation here. Sometimes this facial vein may drain into directly into the external jugular vein. It may drain into the lingual vein. It may join the retromandibular vein to form the common facial vein, which is the usual description, but there is a remarkable variation in anatomy here. And the lymphatic drainage is into the submandibular lymph nodes. As I said, submandibular lymph node is a broader term. It includes both the glandular lymph nodes, it includes the lingual nodes, which are on the medial aspect of the deep lobe of the submandibular gland, and it also includes the perifacial node. So all of these are the draining nodes for the submandibular glands. Now, nerve supply. This is important for the submandibular gland. It is supplied by branches of the submandibular ganglion. These branches carry all kinds of fibers, the secretomotor fibers, the sensory fibers from the lingual nerve, and the vasomotor fibers from the plexus on the surface of the facial artery. So we'll study these one by one. The secretomotor pathway is the parasympathetic pathway. Now this pathway begins in the superior salivary nucleus in the midbrain. The preganglionic fibers pass through the sensory root of the facial nerve, then into the geniculate ganglion via the facial nerve, travel into the chorda tympani branch through the lingual nerve to reach the submandibular ganglion. So once again, the the secretomotor pathway is superior salivary nucleus in the midbrain, geniculate ganglion, sensory root of the facial nerve, chorda tympani, lingual nerve, and then reaches the submandibular ganglion. From the submandibular ganglion, the postganglionic fibers arise and they enter the submandibular ganglion and they are secretomotor. So that's the involvement of the 7th nerve in the parasympathetic supply of the submandibular gland. And if you look at the sympathetic, this is mainly vasomotor in function. This regulates submandibular secretions through vasoconstriction of the arteries which supplies it, which is the facial artery, of course. So basically, if there is an increased sympathetic activity, this reduces the glandular blood flow causes decreasing salivary secretions and produces an enzyme-rich serous saliva. So this is basically a sympathetic response on the submandibular glands. Now this once again is a schematic diagram of the nerve supply. As I said, superior salivary nucleus and midbrain, seventh nerve, geniculate ganglion, chorda tympani, passes on to the lingual nerve, goes to the submandibular ganglion, from which the postganglionic fibers arise and are secretomotor to the sublingual as well as the submandibular salivary glands. The sympathetic supply is derived from the cervical sympathetic ganglia, which passes their nerves to a plexus on the surface of the facial artery, and which provides sympathetic supply, which is vasoconstrictor to the submandibular and the sublingual salivary glands. So the main production of the submandibular gland is saliva. As I said, this is majorly a serous kind of saliva, and it also provides the baseline stimulation as well as the baseline secretion as well as the secretion on impetus. Okay, so it provides baseline as well as impetus secretion of saliva. The contents of the saliva is mainly water, electrolytes, and mucus. 3:2 ratio, as I've already mentioned. It also has antibacterial compounds, enzymes, cells, and opioorphin, which is a newly researched pain-killing substance found in human saliva. Now, I actually lost a few slides on the sublingual gland because my computer crashed twice, but I'm nevertheless going to mention sublingual gland. So sublingual gland is the smallest of the three glands. It weighs about 3 to 4 grams. It lies beneath the oral mucosa on the ventral surface of the tongue, as we already mentioned. The duct has been okay. So a prize from Dr. Poonam for anyone who mentions in the text box what is the name of the duct of the sublingual gland. But these ducts are not demonstrated well anatomically. So relations of the sublingual gland: above, as I said, superiorly the mucosa of the floor of the mouth, inferiorly the mylohyoid, posteriorly will be the deep part of the submandibular gland, laterally will be the mandible, and medially will be the genioglossus, separated from it by the lingual duct and the submandibular duct. Now let's look at the applied anatomy. So excision of submandibular gland for calculus is done by an incision below the angle of the jaw. Always remember that this has to be at least 2 finger breadths below the angle of the jaw. Remember, we are talking about incision for excision of the submandibular gland. We are not talking about neck dissection incisions, which we'll come to later also. So always remember that the incision for excision of the submandibular gland has to be taken at least 2 finger breadths below the inferior border of the mandible to prevent injury to the marginal mandibular nerve. And the steps for identifying the marginal mandibular nerve, I've already stated that. If you're dealing with just a calculus, then you can incise through the fascia of the gland so that the nerve is preserved and it goes superiorly. If you're doing this for a malignancy, then you have to meticulously identify and preserve the marginal mandibular nerve. An alternative method which was described was the Hayes-Martin method, where you identify the facial nerve, identify and ligate the facial artery at the point where it's crossing the inferior border of the mandible, and you retract the superior part of this ligature superiorly so that the marginal mandibular nerve will be retracted superiorly along with it and be preserved. An important caveat here is that this is not a good method when there are a presence of perifacial nodes. Right. So calculus may be formed within the gland or within the duct. You have to identify where is the calculus. If the calculus is close to the duct opening, then it can be delivered perorally through an incision on the floor of the mouth, keeping in mind the direction of the duct. You can also cannulate that duct. Whereas if you need it for several calculi of chronic salivaritis, then you'll have to do it at the external by the external approach. So that is about it for today. We had a small session today because we'd already covered parotid in the previous part. If there are any questions, I'll be happy to take them. Yes.
Thank you, Dr. Abhishek. Great
No,
class. Yeah. So if any questions, please put them on the chat box. So 2 people have replied to your question for
Correct.
the duct of sublingual, that is duct of Rivinus.
Correct.
So I am also not sure what what prize should we be giving.
I'll give the prize.
So there is one question. What was the anatomy app used, sir?
Yes,
Okay.
so these are videos by Acklands, ACLAND, who was a plastic surgeon who has done brilliant videos for anatomy, and I encourage all of them all of you to look at the videos. Now, there's a question from Dr. Ram Pawar: when to preserve submandibular gland in neck dissection? Now, Ram, this is an interesting question. See, there have been studies which have demonstrated the direct involvement of submandibular gland in cancers of the oral cavity, and usually submandibular gland is not involved unless there is a node with extranodal extension in the submandibular region. So theoretically, in principle, in every neck dissection, you can preserve the submandibular gland. I said theoretically in principle, but what are the practical aspects of it? As I said, the submandibular lymph nodes. Now, they may be the perifacial nodes, they may be nodes along the gland or the inferior surface of the gland, and in fact, they may be the nodes at the anterosuperior aspect, which are known as the lingual nodes also. Now, to preserve the submandibular gland while successfully and oncologically correctly taking all of these nodes is a little difficult. So while the submandibular gland is not directly involved, and in theory you can do a transposition of the submandibular gland while doing neck dissections, for beginners it is advisable that you always take the submandibular gland in your neck dissections. For someone who's experienced, and especially for tongue cancers or let's say pharyngeal cancers where there is a very less likelihood of submandibular nodes being involved, you can spare them. Of course, always sparing them in larynx and thyroid, where one nodal dissection is not done. Dr. Poonam, would you like to add anything to that?
Yes, Dr. Abhishek, I think you have already told most of the points. There is one study which we did at TMH some time back. I think Akshat was the first
Yes.
one to write this, and I had initiated it so with Pankaj sir. So there the study was simple, and what we did was that we just looked for the lymph nodes around the submandibular gland while doing the neck dissection. So we saw the nodes which were there anterior to the gland, posterior to the gland, superior, inferior, and anterior, posterior. So we just looked at how many nodes are there. And but the practical aspect was that when you do the deep the nodes which you have to clear deep to the submandibular gland, it is usually not easy. So you will leave behind some nodes, and doing it as a study, and in fact in that also, after removing the nodes, we remove the gland also. So I think unless we prove that it is safe to save the submandibular gland, we should not be doing it as a part of routine. So we should be removing the gland always, even though submandibular gland will not be harboring any nodes.
Couple of more questions, I'll take them, but before that, I'll once again rephrase that. For beginners in oral cancers, always take submandibular gland. For larynx, hypopharynx, obviously we are not doing level 1B dissection, so obviously we are sparing that. Now, from Dr. Ashi, how can we approach the duct directly for stone removal without removing the gland, and in which cases we can do this? Now, this is to be done only if there is a solitary stone which is documented by imaging, which is close to the duct opening. So only then you can do it. You take a per oral approach, and you take an incision along the stone and the duct, and you can remove it directly. You can also dilate the duct opening and retrieve it from there. Style endoscopy has also been used for this. For multiple stones or stones within the substance of the gland, usually if they are not responding to conservative lines of treatment, you'll have to do gland excision. Next question from Dr. Samima. In larynx and thyroid, does it make difference if we ligate facial vein or not? So as I said, facial vein has various anatomy. And if your facial vein is draining into the external jugular vein or the anterior jugular vein, then you might occasionally be required to ligate it. Otherwise, for larynx and thyroid, you're not required to ligate the facial vein. Yes, I think that that covers that question.
I think there is one more question. If we are preserving the submandibular gland in continuous...
Okay. So Dr. Samima is asking, let's say that in thyroid or larynx, you have ligated the facial vein. However, you have preserved the submandibular gland. Then what will happen to the venous drainage of the gland? Is that the question? Yeah.
Yes.
Yeah. So usually most organs have multiple arterial and venous drainages. So it's not like it's a flap, and if you've taken that, then the gland will congest or anything. The gland will continue to drain via submental vein into the contralateral aspect via branches of the lingual vein. So not an issue. You can take that.
Correct.
Are there any other questions?
Not right now. I think you have already covered most of the aspects because it was a relatively smaller topic.
Yes, because we'd already covered parotid at the last time.
Yeah.
Always remember when you're doing neck dissections or whenever you're doing surgery for submandibular gland, the three nerves which have to be preserved are the marginal mandibular nerve, which is right at the beginning, the lingual nerve, which will be seen, as I said, as you expose a deep part of the gland, and the third is the hypoglossal nerve. Now, the hypoglossal nerve will usually not even be approached if you're doing this surgery carefully. The hypoglossal nerve lies a fascia deeper to the deep surface of the superficial part of the submandibular gland. So as you lift the superficial lobe of the submandibular gland, there will be a fascia, and then deeper to it will be the hypoglossal nerve. So while I completely agree that the marginal mandibular nerve is at risk and the lingual nerve, if you are not too careful, but unless you are very gross in your surgery, you will not hit the hypoglossal nerve.
Correct. So if there are no more questions, we can conclude today's class. I thank you, Abhishek, once again, because you took time from your very busy schedule and took last time you took class when you were having high-grade fever. So I really thank you.
Thank you very much. I think that class was more important because of the surgical anatomy of parotid. This was a smaller part, but nevertheless, there we are. Where to access Ackland's videos? Okay, maybe if you can direct message me, then I'll tell you how to access them. But they are also available through the Lippincott website for sale. Okay, thank you so much.
Thank you, Abhishek.